Before anyone orders an X-ray, your patient may already be dying. Imagine you're working in the emergency department when a patient suddenly arrives in severe respiratory distress. They're gasping for air, their oxygen saturation is falling, blood pressure is dropping. They look anxious, restless, and critically ill. As you begin your exam, one finding immediately stands out. You can barely hear breath sounds on one side of the chest. Now your mind should be moving quickly. Is this severe asthma, a massive pulmonary embolism, cardiac tamponade, or is something even more immediately life-threatening happening? When a patient is unstable with severe respiratory distress, hypotension, and absent breath sounds on one side, tension, pneumothorax should immediately move to the top of your differential diagnosis. This is one of the few true medical emergencies where the diagnosis is made clinically, and so treatment cannot wait for imaging. So what's actually happening? Air has entered the pleural space through a one-way valve mechanism. With every breath, more air becomes trapped. Pressure inside the chest continues to rise, collapsing the affected lung while shifting the mediastinum toward the opposite side. That increasing pressure doesn't just impair breathing, it compresses the great veins returning blood to the heart, dramatically reducing venous return and cardiac output. The result is obstructive shock, and if the pressure isn't relieved quickly, the patient can progress to cardiac arrest. This is why every minute matters. Begin your initial stabilization with supplemental oxygen, intravenous access, continuous cardiac monitoring, and pulse oximetry. But here's the critical point. Treat the patient, not the picture. In an unstable patient with classic findings, do not delay treatment for a chest X-ray. The diagnosis is clinical. Treat first, confirm later. Immediate needle thoracostomy is the life-saving intervention. As soon as the chest has been decompressed, follow with definitive tube thoracostomy using a chest tube. Needle decompression first, chest tube second. Only after the patient has been stabilized should you obtain a chest X-ray to confirm lung re-expansion and verify chest tube placement. Because chest pain is a common presenting symptom, it's also reasonable to obtain an ECG and cardiac biomarkers such as troponin to evaluate for alternative cardiac causes when appropriate. These studies can be obtained alongside resuscitation, but they should never delay decompression when the clinical picture strongly suggests tension, pneumothorax. After stabilization and chest tube placement, admit the patient for continued monitoring, repeat imaging, and observation to ensure the lung remains fully expanded. That's the pattern. When you recognize the presentation, understand the underlying physiology, and know the key management priorities, this diagnosis becomes much easier to identify in clinical practice. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.